Okay, so now we're going to discuss about test drain insertion. Uh, so first, second, third step as usual, like previous. Introduction, then confirmation and explanation. Introduction will be, hello, I'm Dr. Shubhanshu, one of surgical residents or one of surgical doctor. May I confirm your name and age, date of birth, please? Introduction done and confirmation also done. Now explain. Today I have been asked to insert hollow tube to your chest to review your shortness of breath. This will be under sterile condition with numbing agent. So you will not feel any pain. Is that okay with you? Also, I would like to check WHO checklist. Can you please confirm your ID number? It will be written in the bracelet and the patient's hand. Also, I will ask, do you have allergy with any medicine, especially iodine, gloves, latex, anything? Are you taking any blood thinner agents? Are you taking any medicine, especially any blood thinners? As it is a chest drain, so some respiratory medicine also. Are you suffering from any chest disease or some chest disease like breathing difficulty, shortness of breath? Are you using any inhaler? Okay. Now I will collect my equipment. So I need sterile gloves and gown, then skin preparation solution, that is iodine and chlorhexidine, skin preparation solution, iodine and chlorhexidine, iodine or chlorhexidine in alcohol, sterile drapers, sterile drapes, 10 ml syringe, needles, 21 to 25 gauge, okay, 10 ml syringe and needle size 21 to 25 gauge. And gauge swab, local anesthetics, that is 1 to 2% lignocaine, scalpel and blade number 11. BP blade holder or scalpel and blade number 11. Suture material number 1 silk. Suture material will take number 1 silk. And large homostat or Spencer. Large homostat or Spencer well clamp for blunt dissection. Well clamp for blunt dissection. Large homostat or Spencer Wells clamp for blunt dissection. Large bore chest tube. Large bore chest tube, 24 to 30 inches. French, sorry, French. Large bore chest tube size 24 to 30 French. Divided by 3, give in millimeter. Okay, that's okay. Okay, 24 to 30 French. Yes, French. Connecting tube, closed drainage system, underwater seal and occlusive dressing. sleep tape. Okay. Now position. So there is no pop-up note. This is the main material. Site. Although variations have been suggested, the safe triangle or safety triangle for insertion of a chest drain has the following borders. Safety drain has the following borders. I will just take my pen to draw this triangle. Safety triangle. So safety triangle, posterior margin by mid axillary line, posterior margin, mid axillary line, anterior margin, inferior margin, and apex. The anterior margin, lateral border of the pectoralis major, inferior margin, fifth intercostal space, and posterior margin, mid axillary line. Some literature states that the anterior border, yeah, we are familiar with this. Anterior border of the latissimus dorsi to be the posterior margin, but if this is taken as a landmark, then the insertion point will be in the mid axillary line where the long thoracic nerve lies. There's a big difference, right? We are not aware of this. So posterior margin is mid axillary line. Anterior border is by this is uh, okay, this is pectoralis major. Anterior border of posterior border. Anterior margin is lateral border of the pectoralis major. Inferior by fifth intercostal space above sixth rib, and apex below the axilla, and posterior margin is mid axillary line. It should be like this: mid axillary line for the axilla, so it will be mid axillary line. And here I think mid behind this, so posterior margin is by mid axillary line, anterior margin by this is pectoralis major, and inferior margin by fifth intercostal space. So this is ultimately the safety triangle. Now, ideal placement should be, again, ideal placement should be just anterior to the mid axillary line within this triangle to avoid damage to the long thoracic nerve of Bell. Long thoracic nerve. Okay. The ideal placement should be just anterior to the mid axillary line within this triangle to avoid damage to the long thoracic nerve of Bell. Blunt dissection should be over the superior aspect of the inferior rib in order to avoid damage to the intercostal neurovascular bundle. Okay. Anesthesia. Lignocaine or similar is infiltrated to the skin and periosteum of the superior margin of the inferior rib. Again, lignocaine or similar is infiltrated to the skin and periosteum of the posterior margin of the inferior rib. There is no evidence that local anesthetics with adrenaline reduce the risk of iatrogenic hemothorax. So, pain we can use. The skin is tested before any incision is made. Despite local anesthetics, the procedure is poorly tolerated by patients. Despite local anesthetics, the procedure is poorly tolerated by patients, and concomitant anxiolytics or opioids are recommended by the BTS. Okay, now insertion. Make a skin incision parallel and just above the rib below. Make a skin incision parallel. Make a skin incision parallel and just above the rib below, slightly stronger than the tube diameter, slightly longer than the tube diameter. 1 French is 1/3 millimeter. Okay, so if we take, we have taken 24 to 30 French. So 30 French, if we divide by 3, it will be in millimeter. So 24 is equal to 24 will be, ultimately it will be 8 to 10 mm, not cm, it will be mm. 8 to 10 mm. One French is equal to 1/3 mm. Use a large homostat or clamp to blunt, dissect through the parietal pleura before doing a finger sweep. Use a large hemostat or clamp. Use a large homostat or clamp to blunt, dissect through the parietal pleura. Use a large homostat or clamp to blunt, dissect through the parietal pleura before doing a finger sweep. Before doing a finger sweep, a small clamp can be attached to the end of the. A small clamp can be attached to the end of the tube through one of the holes to guide placement. Aim the tube typically aim the tube typically for pneumothoraces and basally for hemothoraces. Watch the tube fogging to confirm appropriate placement. Aim the tube typically to pneumothoraces and basally for hemostasis. Watch for tube fogging to confirm appropriate placement. Suture the drain in place a stay suture with a stay suture and pass a horizontal mattress closing suture but leave this untied. The end of the closing suture can be converted in sleek or a transparent adhesive bracing with the drain to stop it coming loose. Now drainage. A unidirectional closed drainage system such as the underwater seal drain is most commonly used. Connection tubing is used between the chest tube and underwater drain. Connection tubing is used between the chest tube and underwater drain. Before the procedure is completed, it is essential to ensure that the fluid within the tube is moving with respiration, showing or bubbling, swinging or bubbling, swinging or bubbling. Post procedure, it is essential to obtain a chest X-ray to ensure appropriate tube placement. Now, questions. Indication for contacting thoracic surgeon. Indication for contacting thoracic surgeon. When we will contact thoracic surgeon. Okay. Persistent pneumothorax. Persistent pneumothorax despite drainage may suggest a bronchial tear. Persistent pneumothorax despite drainage. Persistent pneumothorax despite drainage may suggest a bronchial tear. If it is hemothorax, more than 1500 ml of blood immediately evacuated by tube thoracostomy. 1500 ml of blood immediately evacuated by tube thoracostomy. So again, persistent pneumothorax instead of uh, drainage, and it suggests a bronchial tear. And hemothorax, also more than 1500 ml of blood immediately evacuated after insertion of the tube. Persistent bleeding, which is 150 ml per hour to 200 ml per hour for 2 hours to 4 hours. Okay. Consistent or persistent bleeding of 150 to 200 ml per hour for the next 2 to 4 hours. Persistent blood transfusion. Persistent blood transfusion is required to maintain hemodynamic stability. Persistent blood transfusion is required. Persistent blood transfusion is required to maintain hemodynamic stability. Persistent blood transfusion is required. Persistent blood transfusion is required. Persistent blood transfusion is required to maintain hemodynamic stability. So, triangle of safety, mid axillary line. This is lateral border of the pectoralis major. Intercostal space. Then infiltrate the local anesthetics just above the lower rib. Then insertion of a um, blunt dissection. Again, insertion of children. Triangle of safety, opening of the skin, muscle, and pleura. Blunt dissection of the parietal pleura. Suture, suture placement. Okay, suture placement, but not time. Suture placement. Uh, Gauging the distance of insertion. Gauging the distance of insertion. Digital examination along the tract into the pleural space. digital examination along the tract into the pleural space, withdrawal of the central trocar, and positioning of brain. Underwater seal chest drain bottle. Okay, so this was all about chest drain insertion. Now we'll go for
Having reviewed over different disturbances over the past few lessons that we talked about for the pleural space,
I'm Dr. Jess Mason, and this is a method for chest tube placement. Before you get started, make sure your patient's pain is well controlled and secure their arm up behind their head with tape or a restraint. I want to make sure this guy doesn't move. Once you're sterile, prep and drape a wide area to keep a large field visible throughout the entire procedure, from clavicle to costal margin, sternum to mid-axillary line. Then you're going to palpate down to the 4th to 5th intercostal space in that anterior axillary line. That's the spot. Now let's go get our equipment set. Take the large Kelly clamp and clamp the tip of the tube. Some people alternatively will go through that distal hole. There's no right or wrong answer. Take the second Kelly clamp and clamp the other end of the tube to prevent fluids from gushing out. Now, let's anesthetize the skin. Make a wheel at the skin, and then you're going to aspirate as you insert the needle. You'll know when you get in the pleural space because you'll get a gush of air or fluid back in the syringe. Then you're going to inject liberally as you withdraw the needle. Give that a minute to take effect, and then you're going to make your skin incision. So take your 10 blade and make a nice long skin incision. And now we're going to bluntly dissect with our Kellys, the small Kellys. Remember, we're going one rib space up because there's a neurovascular bundle that sits at the inferior margin of every rib, and we want to avoid that. Hold the Kellys here so you don't accidentally insert them too far. And insert the Kellys. Now, if you're new at this, it takes more force than you might expect, and it really does feel like a pop. That was it. That's in. Spread the Kellys open to create a hole in the pleura and insert your finger. Withdraw the Kellys. Now, I want you to feel right now, in this moment, that you are in the pleural space. So feel the inside of the ribs, feel the lungs, feel for adhesions. That's in for sure. Now we can take our chest tube, and we're going to insert it supero-posteriorly towards the apex. Guide it along your finger and insert it until the last hole is all the way in. Perfect. Now we're going to suture it in place. So get your O-silk, and remember, there's no proven superior method for suturing in a chest tube. Here's one method that I like. We're going to make a simple interrupted suture on one side. Pull through so you have equal ends of suture on either side, and tie a surgeon's knot. This is your anchoring knot. Wrap the ends around the tube and tie. First, I use zero form. Next, I use gauze that I've pre-cut out. Now we're going to tape it in place.
Nice.
Now we're going to pinch the tape around the tube. Now we're going to connect our chest drain gracefully. Cut the end off. Connect your tubing and remove the clamp.
Boom.
Get your x-ray and you're all done.
One. Pediatrics.
Chest tube placement by Dr. Christopher Weldon.
Hello, my name is Christopher Weldon. I'm a surgeon and intensivist at Children's Hospital Boston in Boston, Massachusetts in the United States.
Hey, and welcome to Behind the Knife. I'm Michael Vu. I'm going to be one of the new voices and faces of BTK this academic year, and I am really excited to be introducing you guys to our brand new YouTube video series all on basic bedside procedures. This first episode is all about the humble chest tube. I'll talk about the equipment now. I will list all the equipment in the video description. In the room, you grabbed a knife like this 15 blade and a chest tube. And if you're in an emergency situation, that's actually all you need to just get the thing in, that and your finger. But if you have the time, you should be getting some more things, including pairs of long, skinny, curved clamps. Classically, these would be Kelly's. And for any procedure, I always recommend you have a generous pack of gauze. And unless you're in a trauma or crash situation, you should have something to prep and drape with. So here I've got a stick of chlorhexidine and a thyroid drape. In a similar vein, unless the patient's already anesthetized, you should bring some local with you, as well as a syringe and needles to draw it up and inject it. I like bringing the emergency room laceration tray from my hospital's ED because it includes the syringe and the needles I need, and it also has some extra towels and sponges. You'll need something to sew your chest tube in with, so I brought with me an O silk on a cutting needle. You'll want it to be pretty big, like an O. If it's too small, you may break it when you're tying with it. And you'll need a pair of needle drivers as well, which comes in my laceration tray. If you brought suture on a Keith needle, then you may not need your needle drivers. Last and not least, you'll need some PPE, not pictured here. So grab some headgear, eye pro, a mask, and a gown and gloves. A quick note about chest tube sizes. We used to put some monster chest tubes into people, like 40 French. These are very painful, and most modern research has shown that smaller chest tubes in the range of 24 to 28 French are more than sufficient for most applications. Obviously, your clinical judgment should prevail, and if you know you're doing a really thick, nasty empyema, you may need to go bigger. For any procedure, you should always consider patient positioning before you start. So, lower the head of the bed until it is flat and raise the entire bed until it's at a level that is comfortable for you to work in. Slide the patient over to the edge of the bed that you'll be working on, and have an assistant stand cephalad to you on the side that you're working on to hold that arm up and out of the way. Alternatively, you could put a restraint on that arm and hook it up to the bed if you don't have an assistant. Get the patient's gown out of the way and take this time to really examine your procedural site. Remember, your target is going to be the 4th or 5th intercostal space at the mid-axillary line. The best landmark to use in a male would be the nipple, and in a woman, it'd be the inframammary fold, or the breast crease. And with the preparation out of the way, it's time to gown and glove up. All right, all sterile. Again, unless you're in a crash situation, go ahead and start prepping and draping the field, keeping in mind where your landmark is going to be so that you're going to be able to access it. And for demonstration purposes, I'm putting the thyroid drape on here upside down on purpose to show you guys that if you don't have a lot of drape at the foot of the bed with whatever drape you decide to use, you can use the water seal suction canisters, sterile sheeting that it comes in. That'll give you some extra sterile field at the foot of the bed. I do like to open the atrium sterilely at the very beginning, so it's easier for me to hook everything up when I'm done. And one really important thing not to forget is to fill the water seal chamber with the layer of water that it needs to actually work. So in the atrium, you take out this little tube of water on the back and you squeeze it into the blue nozzle. I've relied on nurses to do this for me before, and they remember like 99% of the time, but every so often they'll forget, and that's dangerous. By the way, if you want a short video on how to read and use the atrium water seal suction device, leave a comment below. At this point, we continue with opening the rest of our equipment. Pretty helpful to have an assistant with you to help you do that. If you're alone, you really have to plan out in advance opening all this stuff on a sterile field that you create before you gown and glove up. If your patient is really cooperative or unconscious, you can open up your stuff on the sterile field you've created kind of next to their legs. I find this really helpful because there's a lot of room there. But if the patient is a little jumpy, I would not do that because their legs could move and bump your equipment. Last bit of prep, I promise, but make sure you clamp the extracorporeal end of the chest tube. Otherwise, when you put it in, you'll have a mess on the floor. All right, with the prep out of the way, let's get down to the good stuff. So draw up some local and get to injecting. These are very painful procedures, so you want to make sure that the patient has adequate anesthesia. My technique is to first start by making a little skin wheel with the local, and then I kind of drive the needle down until I hit the rib. Once I've hit the rib, I inject the periosteum right there. Then I maneuver the needle kind of over the rib and go a little deeper until I've hit the pleura, and I will inject liberally there. Finally, I slowly withdraw the needle and inject on my way out to get the entire tract. Wait about 5 minutes and then do a little skin test with a sharp instrument to make sure the patient can't feel. And finally, we're ready to get to cutting. So feel again for that intercostal space. Make sure that your trajectory is going to be taking you over the rib, and then make that incision. It should be 2 to 3 centimeters transversely, just over that rib. Now pick up that second pair of Kellys you brought with you and insert it into the incision. Now apply firm but steady pressure down toward the chest wall over that rib until you feel you pop through the parietal pleura. And notice I'm holding the Kellys out high on the neck of the clamp, and I'm bracing the clamp with my left hand. That will help prevent you from diving the clamp too deep into the lung. Our SimMan actually makes a really good sound.
That's actually good.
Back up the Kellys so that just the tines are in the hole, and then give a generous spread as you withdraw to dilate that tract. Put your finger through that tract and follow it all the way down to the pleural cavity. And if you're not in the cavity, you know you didn't make it through the pleura. Sweep the underside of the chest wall 360 degrees to make sure the lung isn't stuck up against the chest wall somewhere. Now take that pair of Kellys and clamp the end of the chest tube like this. Notice that it's through the last hole, and the clamps are roughly parallel with the chest tube. Use those clamps to guide the chest tube through the tract over the rib. And then you can use the clamp to help you guide the chest tube either apically, that is toward the head, or basally. Apical chest tubes are suited for draining air, while basal chest tubes are suited for draining fluid. Advance the chest tube until that last drainage hole is all the way in the body, and then put it in another 3 to 4 centimeters just for good measure. You don't want the chest tube slipping out of the body later and one of those holes open to the air. Unclamp the extracorporeal end of the chest tube and then attach it to the Christmas tree adapter on the atrium. Make sure the clamp on the tubing is also unclamped. Home stretch now. All you need to do is sew this thing in. So take your suture and needle driver. There are a lot of ways to sew in chest tubes. You could put in a nice U-stitch, which allows the person removing the chest tube to use that same stitch to close the skin. But what I'm showing you here is going to be a really simple anchoring stitch that does not have that functionality. So I throw the needle through the bottom part of that incision so that when I tie the knot there, it serves to partially close up that incision, make that skin snug up against the tube. And then we just cut the needle off. If you want to look slick, you can use the cutting needle itself, but a pair of scissors works just fine. Tie down a strong knot with the skin to cinch that skin up against the chest tube and anchor the stitch to the skin. And then take the 2 tails of the suture and wrap them once around the chest tube each, and then tie them down onto the chest tube. Make sure that you are making that knot plenty tight. Don't pull too hard or you'll break the stitch, but definitely want to have the suture grabbing onto that chest tube. It's helpful to know how to tie a slipping knot so you can just push that knot down onto the tube. And then I wrap the remaining free ends around the tube several times each, and then I tie another nice tight knot down onto the tube. Now you can dress the chest tube how you want. Some people will put some Zeroform over it before applying a little gauze sponge like I've done right here. I just cut a little slit in that gauze. And then you can put your tape of choice, which a lot of people like foam tape for this. And that's it. Hand the atrium to a bedside nurse or assistant who can help you hook it up to wall suction, clean up your sharps, and get the drapes off. And one thing to remember for either yourself to do or for the nurse to do is to reinforce the Christmas tree connections with some tape. So notice here Dr. Franco is using some skinny strips of tape and kind of spiraling it around the connection. He'll use a few strips of tape to do this, and we like to do it this way instead of just wrapping the whole thing in one thick wad of tape, because if you do it that way, then you won't be able to see the actual connection if you need to troubleshoot it later. And there you have it, how to place a chest tube. Hey, I really hope you guys enjoyed this video or learned something from it. If you liked the video, please hit that like button down below.
Okay. So that's it.